A 76-year-old male presented with chest pain. I am showing you his chest radiograph. Describe the findings.
Right, so the AP chest radiograph demonstrates a large mediastinal mass on the left. The arch of the aorta and proximal descending aorta are not seen separate from this mass, indicating a posterior mediastinal origin. There is curvilinear calcification along the lateral margin of this mass. This suggests a dilated aneurysmal thoracic aorta.
Given these plain film findings, what is your primary diagnosis?
The primary diagnosis is a thoracic aortic aneurysm.
What is your differential diagnosis for a posterior mediastinal mass?
The differential diagnosis for a posterior mediastinal mass includes thoracic aortic aneurysm and a dilated oesophagus. Other causes are hernias like a hiatus or Bochdalek's hernia, spinal abscesses, extramedullary hematopoiesis, and neurogenic tumors.
I am displaying an axial contrast-enhanced CT image of the chest. Describe the findings.
As seen in this axial contrast-enhanced CT of the thorax, there is a large descending thoracic aortic aneurysm. There is a marked amount of peripheral thrombus present. Surgical repair is considered when descending thoracic aneurysms exceed 6 centimeters in diameter.
How do you radiographically divide the mediastinum? And what are the key differentials for the anterior and middle compartments?
The anterior mediastinum contains the thymus and lymph nodes, and its differentials include thymoma, teratoma, retrosternal thyroid goiter, and lymphoma. The middle mediastinum contains the heart and trachea, with differentials including lymphadenopathy, bronchogenic cysts, and ascending aortic aneurysms. The posterior mediastinum contains the descending aorta and esophagus.
I am displaying a comparison frontal and lateral chest radiograph from another patient with a left-sided mass. Describe the findings and silhouette sign, and name the diagnosis.
This frontal chest radiograph demonstrates a well-defined round mass related to the left heart border, but with preservation of the heart silhouette. On the lateral chest radiograph, the mass is confirmed to lie in the posterior mediastinum, consistent with a neurofibroma.
In an acute emergency, how do you distinguish a simple aneurysm from an acute aortic dissection on a chest radiograph or CT?
In the acute situation, plain film signs of dissection include rapid mediastinal widening, a fuzzy aortic outline, and displacement of intimal calcification. CT angiography can definitively distinguish them by demonstrating an intimal flap separating the true and false lumens in a dissection.
How would you manage this patient as a radiologist?
I would compare the chest radiograph with previous films to assess for any interval increase in mediastinal width. I would communicate the findings of a large posterior mediastinal mass with curvilinear calcification immediately to the referring clinician due to the high risk of a thoracic aortic aneurysm. I would recommend an urgent contrast-enhanced CT angiography, CTA, of the chest and abdomen to measure the maximum aneurysmal diameter, assess for wall tension signs, and rule out acute dissection. Given the clinical presentation of chest pain, I would recommend immediate vascular or cardiothoracic surgery referral and strict blood pressure control using intravenous beta blockers, as descending thoracic aneurysms over 6 centimeters carry a high risk of rupture.